Good evening, everyone. Welcome to today's webinar on deprescribing of proton pump inhibitors in Alberta, brought to you by the Physician Learning Program in the Office of Lifelong Learning. I'm Denise Campbell-Scher. I'm the Associate Dean of the Office of Lifelong Learning and Physician Learning Program here at the Faculty of Medicine at the University of Alberta. Our office is committed to providing the latest information, advice, and resources to support continued educational needs of healthcare professionals and their teams. You will get to see some of the tools that were co-created in collaboration between the Digestive Health Strategic Clinical Network and the Physician Learning Program shortly. So we acknowledge that we are on the traditional territories across Canada, the many First Nations, Métis, and Inuit, whose footsteps have marked these lands for centuries. So it is my great pleasure to introduce Dr. Sander van Zanten to present today on the topic of deprescribing proton pump inhibitors in Alberta. Professor Van Zanten studied medicine and did his internal medicine residency training at the University of Amsterdam in the Netherlands, followed by a master's degree in public health from Harvard University. He then did internal medicine training and research fellowship in gastroenterology, followed by a master's degree in clinical epidemiology at McMaster University. He worked at the Queen Elizabeth II Hospital in Dalhousie, at Dalhousie University in Halifax, and obtained his PhD in medicine for a thesis on clinical aspects of Helicobacter pylori infection. In 2006, he moved to the University of Alberta as the Director of Gastroenterology Division and Section Head of Gastroenterology in the Edmonton Zone. He has a special interest in upper GI disorders, including Helicobacter pylori. Since 2017, he's been the Senior Medical Director for the Digestive Health Strategic Clinical Network in Alberta. So welcome, Sander. Thank you so much for coming this evening.
Thank you, Denise, for that nice introduction, and thank you for all of you in the remote audience for tuning in. So what I'm going to talk today is a lot about how to prescribe, but especially opportunities for deprescribing proton pump inhibitors. So here are my conflict of interest. None of this is relevant for this presentation. Yeah. So what I'm hoping to do is tell you a little bit about the extent of how often PPIs are prescribed across Alberta, and then with you identify appropriate situations where you might consider deprescribing or diminishing PPI's dosing. I hope throughout this talk you will start reflecting on how you use PPIs in your practice and whether there are opportunities to improve that. And we'll show you some tools that may help you, and towards the end there's a special slide with some links towards these handouts that we have developed and have proven to be useful. So I just want to acknowledge this particular program is also organized by the Physician Learning Program, but we've worked very together both in Edmonton with the PLP, but also in Calgary. And for example, the handouts that I'm going to show you were sort of developed in conjunction with staff at the PLP, and that's been a tremendous collaboration. So just to set the stage, so we have about 4.5 million people in Alberta. So every year, 11% of the population gets at least one prescription for PPI, and a third of those are news, and 2/3 are about refills. And then well over a quarter of people apparently are using PPIs long-term. And then an important one is that it highlighted in yellow. So 28% of all prescriptions are started on a twice-daily dosing of PPI, so starting dose. And I'm going to show you that in most instances, there is no real evidence that you have to do that. And from a variety of sources, we estimate that about 40% of people, 40% of all these prescriptions are probably overprescribing. Now, the PPIs, for the most part, have come off patent, so they're now relatively cheap drugs. But so in Alberta, the total cost is like 48 million, and 60 million of that is through the public Blue Cross program. But across the board, PPIs are in the top 10 of classes of drugs that are prescribed, and this is especially common in the elderly. Yeah. Now, choosing wisely, and I'll show you the quotes from GI, from the hospital pharmacists and the Canadian pharmacists have all committed to say to make attempts to deprescribe. Towards the end, I'll show you. I'll give you some links to handouts of choosing wisely as well, but I won't talk about that here in detail. Yeah. So just to give you a few things to reflect on, so how many patients do you know are taking long-term PPIs? Do you consider reducing that? We know you're very busy, you have diabetes, hypertension, screening, etc. So PPIs are usually low on the priority list, but there are opportunities. Yeah. How often is the diagnosis actually not that clear? Have you reviewed PPIs when people are discharged from hospital, which is a common occurrence when PPIs are started? And are there options for stopping or diminishing the doses? So what are indications? Really, it's a fantastic class of drug, revolutionized peptic ulcer disease and reflux disease. So GERD is an absolute indication, but you don't have to have esophagitis for this, and more than half the patients of GERD never have esophagitis. Then we have dyspepsia, where there's epigastric pain dominant symptom as a driver. Of course, peptic ulcers. It's interestingly also part of Helicobacter treatment. Well, the drugs, the PPIs were never developed for that, and the same for NSAID prophylaxis. So if you look at this list of indications where upper GI disorders are so common, PPIs haven't made. And I'll say a little bit more about GI bleed prophylaxis, but this may be a group where PPI, especially the elderly, is somewhat underprescribed. Now, I'm not expecting for you to read this handout, but this is what we developed together with the PLP, tremendous work. The main indications, and if you go through the sheet or put it on your desk, it tells you how to start, how you can evaluate response to therapy, and what the criteria are for referral to a GI. So I've used this, it's proven to be very helpful. We'll show you the link to this handout, which is listed here, and it's towards the end on a separate slide. And as said, I'm not going to talk about it in details. Choosing wisely also has a special toolkit related to Deprescribing of the PPIs, just so you're aware. Yeah. I just want you to reflect a little bit. PPIs are commonly prescribed. We generally don't worry about them for prescribing. So, if you look at this list of potential side effects, are these causal or are these just associations, such as osteoporosis, dementia, occurrence of microscopic colitis where you have diarrhea, where only biopsies show abnormalities, slight increased risk of infections, and PPIs can rarely, but not frequently, cause also chronic kidney injury. Yeah. So the PPIs, and this is the reason I think they're so often overprescribed, is they have a tremendous safety profile. You generally don't have to worry about things when you start it. So most of the associations of bone fractures was a hot topic a few years ago. Dementias more recently, they've shown not to be causally related. And in the elderly, like in nursing homes, 80% of residents in some nursing homes are on PPIs, and that's probably overprescribing. But PPIs do cause a slight increased risk of enteric infections and C. diff, and that's probably related because acid, one of the main functions of acid is basically keeping dirty bugs out of our GI tract. So you have a slight increased risk of getting these infections. Now, malabsorption, they are true, but they are fortunately very rare. So rare that we usually don't have to worry about measuring B12s or magnesiums or iron. Rarely PPIs can cause a watery diarrhea, and if that persists, then you do take biopsies from normal-looking colon-like mucosa. You'll see that there's microscopic inflammation. Usually you can tell because it occurs within a few months after the start of PPI, and you can simply stop in that instance. And then also very rarely kidney damage, but again, it's 1 in thousands. Yeah. Now, which PPI should you choose? Although they're not exactly the same, we consider them to be equivalent. So pantoprazole and rabeprazole are preferentially listed by Blue Cross. For the other PPIs, if you're in Blue Cross, you have to have some copay. Myself, I would not pay money out of pocket for the other PPIs relative to pantoprazole and rabeprazole, and this is also true from Dexilant. So Dexilant has a little bit longer acid suppression, but as far as efficacy, there is, in practical terms, not much of a difference. So personally, I wouldn't worry about that. So I'm going to show you 3 cases. Here's the first case, a 64-year-old guy who's a bit obese at a BMI of 26. comes in for a refill. He has been on a PPI for years, and as it turns out, he's always been on twice a day. He thinks it is for reflux symptoms, but it's not that well documented. And as a risk factor, he also smokes about half a pack a day. So this is an opportunity to go over the medication, the PPI with him. So he remembered that heartburn was the most common, the most troublesome symptom, but as soon as he was on the PPI, it's never bothered him again and for years. Yeah. So, and then the question is, was there ever a firm diagnosis? Well, not really, but the PPI seems to work. Yeah. So to let you think, so how do you diagnose whether somebody has actually reflux disease? And if so, should you do any of these steps? Yeah. Should you screen these for H. pylori? Can you tell by the symptoms? Should you start with twice a day, especially if the symptoms are severe? And do you need an upper GI to actually diagnose GERD? So very importantly, when we talk about symptoms, if somebody comes in with heartburn and or regurgitation rising up in the chest, if that's their dominant symptom, they have GERD, and you should stick with that diagnosis. Yeah. And if there is no heartburn at all, no burning sensation, an acid-related disorder, GERD is very, very unlikely, just as a non-response to PPI and true GERD is basically doesn't exist. So if a patient with lots of heartburn and you give a PPI and it doesn't work, it probably isn't reflux. Yeah. Now the starting dose for PPI, and I'll show you some more data, should be once a day. So once a day, half an hour before breakfast or just before breakfast. And usually what you should do, you give it for 48 days. And what you should expect is that there is a significant improvement in their symptoms. After those 8 weeks, you can tell the patient, you can stop and see what happened. And if they truly have underlying reflux, most of those people within a few weeks will have a relapse. And then you can give them on longer maintenance therapy. So dominant symptoms of heartburn and regurgitation, it is GERD. Start them on a PPI once a day, not twice a day. And here you see some data. So this is all data where they randomize people to either once a day lansoprazole or double dose omeprazole, etc. And these were people that had both heartburn symptoms and esophagitis. And at 8 weeks, there was really no difference between the once daily and twice daily doses. So this is a tremendous opportunity for deprescribing of PPI. Yeah. Now in Alberta, as it turns out, and when you look at that, I've looked at other jurisdictions. Well, if you look at the starting doses, it's very common and people are quite impressive. We are very much used that people come out of the hospital on pantoprazole twice a day for query bleed. So we think that is the normal dosing, but it actually isn't. Yeah. Start with once a day and the symptoms should go better. And this is my question to you. So how often have you started people actually on twice a day instead of once a day? 1 in 4 is the going rate in Alberta. So real indications for starting a PPI twice a day is definitely upper GI bleeding or suspicion thereof as part of Helicobacter treatment, but that's only for 14 days. And if rarely, if you're really worried about symptoms, and where you can start up twice a day, but usually that is not necessary. Now, how do you know that the PPI works? And reflux is the best example of that. Within 4 to 8 weeks, there should be a very significant improvement in the symptoms. There will be a little bit of a subgroup of patients where the response may be so that you're not 100% sure, and then it's probably perfectly reasonable. Double the dose to twice a day. Twice a day is better than double dose once a day, and give that for another 4 to 8 weeks. But what I always tell the patient, you have to look at yourself in the mirror and convince yourself that you're better off with this medication. And the other thing is, this is sort of a trick of the trade, but heartburn severity and frequency you can use as a measure of treatment success as well. So usually if people come in and they have twice a week symptoms of GERD, or once a week more severe symptoms of GERD, studies have shown that their quality of life, their indigestion symptoms are significantly better by putting them on a PPI. And once again, if somebody you thought had reflux disease and they come back 4 or 8 or 12 weeks later and say they're no better, you're probably, the diagnosis is not correct. Now, in GERD patients, over time, quite a few up to a quarter will need to step up to twice a day. They'll lose control to some extent. And that's just perfectly fine. So you start once a day, and then years later, you may have to go to twice a day. And again, it's all about symptom control. But the fact of the matter for you is, since you usually annually review a lot of your patients, this is an excellent segue into consider whether it's possible to either reduce the dose or maybe stop them altogether. Yeah. Now, does it work stepping up medication? Again, this is an old slide. So here you can see in blue once a day to going twice a day, either healing of esophagitis or relief of heartburn in people that lost response or were not responding. The BID dosing is definitely better. And as said, in a quarter of GERD patients, they'll end up on twice a day PPI. So for him, when you review him, so there's definitely opportunities, I think, at least to go to once a day and see what happens. And then as far as risk factor, if we can convince him to quit smoking, smoking more frequently causes people to have reflux. If they have reflux, they don't respond as well to therapy, and they more likely have complications, including Barrett's and rarely adenocarcinoma. Now, what about lifestyle measures? Yeah, so we talk a lot about them, but for the most part, they don't work. So yes, to obvious dietary indiscretions, people eat very irregularly and so on. They need to address it. Smoking, absolutely. And weight loss, yes, if you can, but unfortunately in practice, as you well know, this is hard to do, but smoking would be a bet. I never recommend elevation of the bed, although physiologically it makes sense. I usually find, particularly in couples, that they say, well, honey, if you have reflux disease, why do I have to sleep on an angle? And with the PPI, it's often not necessary. And then the other thing is, I love a good cappuccino. Taking people off good chocolate is malpractice. So don't do it. Then there's no need to do it. So I'm very aggressive about trying to convince them to quit smoking. Other measures I use very little because you either don't need to or they don't work. But you, as family doctor, so like I think the number of prescriptions, it's something well over 90% of all prescriptions in Alberta are written by you. So you are the ideal gatekeepers of prescribing and deprescribing. Yeah. And you starting the conversation with these patients is an important step. So together again with the PLP in Edmonton, we also have, if you so wish, you can download this handout. And people that check in and are taking PPIs, you could give them this little sheet while they're waiting to see you, either now on Zoom or in real life. So my patients, I ask this always in the hospital, why you're on PPI? It's amazing how many people don't know. It says a little bit about the symptoms and whether they feel you're working. And this is sort of basically an initiation also by the patient to come up to you and discuss whether that's something that could be considered. So here's the link to that particular handout. Now, if a patient is on twice a day, I usually recommend go for 4, 8 or longer weeks to once a day and see whether it makes a difference. And then that doesn't make a difference, consider stop. What you need to remember is a PPI is an acid blocker. And what happens is because acid is blocked, the gastrin is sort of upregulated a little bit. So as soon as you stop, there tends to be, and that's been measured, a little bit of an overshoot of acid production in the stomach. And even if you give people, like healthy volunteers, 2 weeks of PPI and then suddenly stop them, they tend to have a little bit more GI symptoms. So there's a little bit of an overshoot of acid and hence of symptoms. So you have to tell patients, listen, if you're going to decrease or particularly if you're going to stop, give it at least 2 weeks or so. Don't jump the gun immediately as soon as symptoms start to appear, because this overshooting of acid production is a very temporary response. But it's important that you tell your patients about it. Okay, so, and I probably don't have to tell you this, but it's teamwork, all these kind of stuff, medication management. So you need to have the conversation. Both you and the patient need to agree what the aim of the game is and how you establish whether this is working. So you have to personalize it. Let's stop first. You decide what the symptoms is, then you can decrease first, and then you can stop. And so the patient it's going to work much better if the patient takes some ownership of this. And it's possible. Yeah. Now, then it's just a few things about GERD, and I'll come back to it. So on the left-hand side, so heartburn and regurgitation make the diagnosis of GERD. More than 50% of people with true reflux disease never get esophagitis. And more importantly, when we do gastroscopies for you, and people have symptoms, I would say 2/3 of these patients are in PPI. So when we say it's normal, it doesn't mean they never had esophagitis. So then there's the syndromes where we want to prevent reflux esophagitis, healing, prevent strictures, and prevent the formation of Barrett's and rarely adeno-CA. When you talk about chronic cough, asthma control, most of that is association, not causation. And the usual way I explain this to people or to a patient, if you have chronic cough and you have heartburn and you go into PPI, the heartburn will get better and the chronic cough is 50-50. If you have chronic cough and you have no heartburn, it's very unlikely that the PPI is going to work. And this is true for all these conditions. Globus sensation, dental erosions, also very much overcalled. And you see this here on this slide. I hope you can see it. The green versus the blue is the therapeutic gain that a PPI provides over placebo. And you can see for like esophagitis, it's sensationally good for the PPIs. But if you go down to hoarseness on the bottom, no difference with the PPI and chronic cough. There's only a very small group of people that actually find benefit with the PPI. So this is this is a real industry, all these so-called extraintestinal manifestations of GERD that we can do better in. Yeah, and I already told you that heartburn severity, so if somebody has symptoms twice a week that are mild or once a week severe, they generally do better on a PPI. Now let's switch gears. We're going to talk dyspepsia. So here's this very nice lady. She's been epigastric discomfort. She is bloated. She's not sure whether the PPI is helping, but she wants it. When you talk to her, she's actually never had much in the way of heartburn and regurgitation. She's definitely a bit overweight and is a non-smoking. Now, is it important from a primary care perspective to make a distinction between dyspepsia, which is epigastric pain dominant symptoms, versus GERD, where you have heartburn dominant symptoms? Both will respond to a PPI, although GERD always responds better. But quite often, it's sometimes hard to make the distinction. And for all sense of practical purposes, it doesn't make that much difference. But PPIs do work. So this is an epigastric pain or discomfort condition associated with excessive burping, belching, maybe some heartburn, etc. So what you see here is on the left, you're less likely to have ongoing symptoms of dyspepsia if you given a PPI compared to placebo. But here's the trick. Dominant symptom is very important. So if you have heartburn dominant symptoms, dramatic improvement. If you have pain or discomfort, epigastric pain dominant, definitely the PPIs are better. But if you have upper abdominal bloating with some pain and discomfort symptoms, PPIs actually don't work. And in that patient group, there's often an overlap with things like IBS, and the PPIs generally don't work. And this is certainly a group of patients where if they're on it, you could definitely consider getting them off it. So just based on this history, and I see lots of people that don't like this, it's unlikely that it's acid related. And often there's overlap with IBS, and you have to take a much broader approach, including sort of IBS management and not so much being focused on acid suppression, which is the thing that PPIs do so well. But it's perfectly reasonable. Sometimes if you're not sure if there's associated heartburn, just give people 4 to 8 weeks the PPI once a day. And you just tell them, you look at yourself in the mirror, doesn't make a difference. If it doesn't, there's no point in continuing. Yeah. Now, the other thing is, what is most common? Upper GI disorders, 5% of all consultations in primary care are related to this. What are the most common causes? So this is a study we did now almost 20 years ago. We took patients from all your practices, more than 1,000, that came in with dyspepsia, epigastric pain with or without some heartburn symptoms, and scoped them without medications within a week. And as you can see, a third were H. pylori positive. And what you can see on the next slide, that reflux esophagitis is significantly more common than gastric ulcer and duodenal ulcers, whereas 30 years ago, this was completely different. Like 25 years ago, I did gastric and duodenal ulcer studies and recruited for that for Helicobacter, and they were relatively easy. Nowadays, it would be hard to do. But the other thing that you can see is, so in blue is the HB positive. If you either go for, from your perspective, go for a PPI, or you go after Helicobacter, particularly in peptic ulcer disease, you virtually target appropriately most patients, which once again is why PPIs are such good drugs. Yeah. Now, when do you need to refer? Alarm symptoms. I think I used a very bad algorithm: vomiting, anemia, evidence of bleeding, abdominal mass or weight loss, and significant dysphagia. But dysphagia is loosely the firm term. It's usually not a globus sensation. It's really the slow passage of food through the esophagus. Many people, where you or your colleagues say dysphagia when we talk, and I say, well, it sounds more like a globus sensation, and often we don't find too much. Yeah. If you had dyspepsia or GERD and you think it was GERD and there's no response to PPI and there's still have ongoing symptoms, definitely. But you don't have to send them in garden variety reflux disease patients who are responding to a PPI, particularly not if they're below the age of 50. So screening for esophageal cancer in GERD is quite controversial, and we feel we can be much more restrictive, mainly in males, mainly obesity, Caucasian, smokers, and over the age of 50. But if for other reasons you're worried, of course, we would love to take the narrow but beautiful view of the gastroscope to help you. Now, here's the third case, which is very short. This is a scenario where you should not deprescribe, and I've seen this happen, unfortunately, a few times. So a 70-year-old male comes in for a refill for pantoprazole. He's had congestive heart failure and an uncomplicated MI, and he's on atrial fibrillation. So he's on a novel anticoagulant, but could be warfarin, and on aspirin. And he had an ulcer 7 years ago. In these patients, and this is also, or if they had significant dyspepsia, I would not stop the PPI, because if there was underlying ulcer disease, he's much more likely to have that complication of bleeding again. And I'll say a little bit more. So in my personal view, if you have some comorbidities, diabetes, obesity, hypertension, and you go on anticoagulation plus an antiplatelet agent, I would have a very, very low threshold putting these people on once a day PPI, because when you do that, the surprising GI bleeds will not occur or will not be due to peptic ulcer disease. So that's an area where you should not stop, and where maybe you could even consider prescribing more. A little bit about NSAID. This is how I think about NSAID. So a quarter of patients get symptoms, smaller proportion get ulcers, and even more smaller complications. But indigestion due to NSAID is up to a quarter of patients if they take a regular doses, which you can decrease by taking it with meal. But if you scope these people, most of these ulcers are small and tend to disappear with time. But the annual risk of complications is in the range of 1 to 4%, even in younger people. And bleeding complications, 1%. And a lot of these NSAIDs, we see this all the time. You go to the dentist, and you had a root canal, and you took the ass, you had dyspepsia, and you had a bleed. A few years ago, they don't read the insert, and they come in with a significant bleed. So we do see this all the time. The other thing is, and this is where I'm coming in with the anticoagulation and the antiplatelet agents. There's about at least 4 or 5 million Canadians taking baby aspirin at the moment. So PPIs work and prevent aspirin-induced ulcer, but the rate is very low. You know, only 3 in 1,000 will get an ulcer or an ulcer bleed. And if PPIs work, that means you have to treat more than 300 patients to prevent one. But once you have an aspirin together with, like, sometimes clopidogrel, and then anticoagulation, either warfarin or NOACs, and you have comorbidities and you're at a higher age category, in that category, in those patients, I would have a very low threshold for putting these people on the PPI. Now, there are a few long-term indications. So if we tell you that a patient has Barrett's, doesn't matter whether they have symptoms, they need a PPI once or twice a day for the rest of their lives. And should that's just the way it is, and I wouldn't argue with it. Gastroprotection, so giving a PPI to prevent ulcers, yeah, definitely in people who have a history of peptic ulcer disease or significant dyspepsia, in particular when they use NSAIDs, are frail, are elderly, and so corticosteroids, in addition, for example, to anticoagulants, is a definite risk factor for upper GI bleeding. So in this patient category, listed on the bottom once again, I would have a low threshold going to the once a day PPI. Here you just see a picture of Barrett's. This is what it looks like. The gastroenterologist will love to follow these patients and will do that for you. Lifelong PPI. Now coming towards the end, you know, I owe my academic career. If I have a claim to fame, which I don't have it, it's probably in the area of Helicobacter. I love this bug, although I'm trying to get rid of it. So what you see here, what I think is a beautiful picture of the gastric mucosa, and you can see there next to these bluish mucus cells, these curved spiral organisms lying there. And the interesting thing is, it's not an invasive organism, but it causes a profound immune response that, if you have the right circumstances, leads to ulcers. And then the other question I pose to you, okay, how do we get antibiotics in this mucus layer? Is this, well, the antibiotics pass the stomach, or do you need systemic absorption and then secretion across this barrier, the gastric mucosa barrier, which I believe is the one that's necessary in order to kill these bugs? Yeah. So in Alberta, we switched a little bit. So we have the urea breath test, but in the Edmonton Zone, we now also have preferentially switched because it's cheaper and a bit easier to the stool antigen test, HB-SET. Under special circumstances, you can do a UBT. Both are excellent tests as far as accuracy for whether the patient has or doesn't have have Helicobacter. So in people who have duodenal gastric ulcers, you definitely need to treat them if it wasn't already done for you. There's good evidence that if you have epigastric pain dominant symptoms, just in primary care, you don't know whether it's ulcer, it makes sense, apart from giving the PPI, go after Helicobacter, because in about 40% of those people, not 100%, you'll cure all their epigastric discomfort by getting rid of HP. Certainly in the family history of gastric cancer, I would test and treat for Helicobacter, and I get these patients quite a bit. And you may consider it in people at high risk, so immigrants, particularly from Southeast Asia, South America, and H. pylori and gastric cancer both are much more common in First Nations people in Canada. But interestingly enough, we don't routinely recommend it in GERD. I'm not saying it's wrong that you do it, but if you have dominant symptoms of heartburn, i.e. GERD, you can get rid of the Helicobacter, but the course of GERD, whether they need ongoing PPI, etc., is not changed. And quite often these people, particularly if they haven't seen much PPI initially, so they have GERD, and then you go after the HP and they feel wonderfully better, which is the PPI in this case for the GERD symptoms. And then you stop and then the symptoms are back and they say, oh my gosh, the HP is still there, which quite often it isn't. So in reflux disease, I'm not saying it's wrong to go after it, but you don't have to. Certainly not at the beginning, but it's not going to change GERD. So don't think that if your H. pylori eradication was successful, that it's not possible to have GERD. GERD patients will have GERD. Yeah. So there are a few new things. So one is the treatment duration is 14 days. No. And then the other thing is, if you ever think about HP pack, drop it. Don't use it. It's more expensive, and you don't need it. Yeah. So this is the new first line. It's called concomitant, but I use the acronym CLAMID. This is not an H. pylori talk, but it's a combination of clarithromycin, amoxicillin, and metronidazole. It's relatively easy to take. 85% successful, so not 100% successful. 14 days. And then the second and third line are either bismuth-based quadruple therapy, I'll list the drugs here, or thirdly, which is an easier combination, the PPI, amoxicillin, and levofloxacin. And you can look up the doses. If you use these three combinations in sequence, 96% of all patients with HP will be cured. Okay, a little bit about when to refer, as I'm close to finishing here. Please describe your symptoms. You'll be amazed how many referrals we get with it. Not saying whether the PPI was given and whether it worked or not. and of course alarm symptoms and some lab test results if they're relevant. So to conclude, there's no question that PPIs are very good, very safe drugs, but there's significant overprescribing, and you as the gatekeepers are the prime people that can maybe start getting this better. Usual starting dose for most indications is once a day, and as a trick of the trade, if upper abdominal bloating is the symptom, it's unlikely to work. So here's the slide, and we'll make you the slides available for the handout. So the Digestive Health SCM together with the PLP has made these handouts, which I showed you, but also very importantly, and I'm not quite sure where you're working, but they're primary care pathways in Calgary and now a Shooter program in the Edmonton Zone, and we're rolling them out, where we give you help in how to manage these conditions and when or when not you have to refer. And there's also a deprescribing algorithm at the bottom. So, and then finally, we are considering doing a audit and feedback sort of deprescribing project. We hope that you might be interested, and if you're willing to be at least approached if and when we launch this particular initiative, you can please scan this in, which allows us to get your email so that we will contact you when we're ready to roll this out and see whether you indeed may wanna participate. So I hope that was useful, and I'm ready to take any questions.
Thank you so much, Sander. I really appreciated all of that review. And just to remind everyone, please go ahead and put questions in the Q&A box. Muriel's getting us started, Sander. She's asking about causative factors for gastric CA, and specifically, is H. pylori the causative factor, or are the others?
So gastric cancer, I mean, it's not that common anymore, but much more common in First Nations people and people that are immigrants, certainly first generation immigrants from a higher risk country. So it's a significant cofactor. And so the attributable risk is about between 50 and 60%. So if we were to treat H. pylori in time, early enough, we would prevent probably up to 60% of gastric cancer. The other really major risk factors, and this is very important in First Nations, is smoking. So that's the other one that's really hard. But yes, if somebody has a first-degree relative, not second-degree, first-degree relative with gastric cancer, I always advise to test and treat for Helicobacter. Yeah.
And can people be asymptomatic, Sander, with Helicobacter?
Yes.
Long term.
Actually, most people are. I mean, gradually over time now, with like you saw that study 20 years ago that the prevalence was about 30% in HP. It's now down to probably between 15 and 20, all comers, all age groups. But so with improved water and sanitation, smaller family size, H. pylori is slowly disappearing. So only 5 to 50% of people get ulcers, and maybe 10 to 20% may get dyspepsia. The large majority of people, and most of them get infected early in life, go through life, and it's completely asymptomatic. And unfortunately, out of the blue sometimes, so the rate is like less than 1 in 1,000 people develop gastric cancer, and usually at a higher age. Okay,
that's really interesting. So Minnie is asking, with so many patients now on the DOACs, are there any studies to suggest which of those patients should go on a PPI, even if patient doesn't have symptoms or has never had an ulcer?
Yeah. So symptoms are not relevant in this. This is ulcer prophylaxis. So I would say certainly above the age of 70, anybody on a NOAC plus an antiplatelet agent, I would consider. So it's usually the two that makes it work. And maybe even 65, but I certainly would consider it in people that have some other, diabetes, hypertension, COPD, kidney disease. All those people are just because of other risk factors at increased risk of having complications. So if I'm 70 and I need a NOAC and they need at least one platelet agent, I'm going to go on the PPI. I'm convinced. And the other thing is that this is what I tell my cardio. So I've convinced my neurology friends when they do all this thrombolysis now and so on, and then put them on NOACs, to put them all on PPIs. And I love GI bleeding, upper GI bleeding as a reason to come out of bed or see patients. The number of bleeds from neurology is significantly lower. If I go into the coronary care unit with an acute MI or something, I said, just give me a PPI for the time that I'm here. So that's my belief.
Mm-hmm. Oh, brings back visuals from some years back. Xander, thanks. Okay, so Theo has a question about whether H. pylori is associated with gastric lymphoma or adenocarcinoma or both.
Yes. So gastric lymphoma, they're usually malt lymphoma. They're small ring lymphomas, are strongly associated with Helicobacter. And 2/3 of these patients, and I've seen, I don't know, in my life, maybe 15 or so, 2/3 of them, you can cure them just with 2 weeks of antibiotics, definite cancers. The other ones that have more deeper invasion, they may need radiotherapy or chemo, but gastric adeno-CA, so about 80% of the gastric cancers are H. pylori positive. So definitely associated, but gastric lymphoma is much rarer than gastric adeno-CA. But gastric cancer is still more common than esophageal cancer. Most people don't realize that, but yeah.
Interesting. Actually, on a follow-up for that, is there any role in people who've got strong family history for doing any screening ultrasounds?
For gastric cancer? No. So what I would do is, but it depends a little bit on your age. I mean, if your parent at age 85 got it and he or she was a smoker, then maybe less. But what I usually tell patients is, when I see them, I first test them non-invasively for Helicobacter and treat them, and then I bring them for a gastroscopy, because for the gastroscopy there, it's not so much whether you see ulcers or not, and so it's what the mucosa, what the histology shows, and this is intestinal metaplasia, where the lining of the stomach becomes more sort of intestinalized. If you have a little bit, I usually forget about it, but if you have more than mild intestinal metaplasia throughout the stomach, and then I say, Denise, this is not evidence-based, come back in 5 years, and this is not unlike. And then and the yield of that is not very high, but I've picked up a few people early that way. And that's I said, I don't have any other, it's maybe overkill, but gastroscopy is still, it's a relatively easy test. So that's what I would do. Non-invasive test for HB, treat, scope once, and then maybe consider every 5 years.
Okay, thanks. So Muriel has a question, just again, which is the most cost-effective proton pump inhibitor?
Well, there's not much price difference. Pantoprazole or rabeprazole at the moment are the cheapest. So, but I mean, even omeprazole, Losec, is not that much more expensive. I mean, Dexilant, Zoprazole, Dexilant. I mean, most private drug plans cover it, but I wouldn't. I see people regularly that on this and do the significant copay of it, and I said, listen, I'm okay with that, but personally, I wouldn't pay that money out of pocket. I would just go to pantoprazole or rabeprazole.
Okay. And with regards to the stool antigen test, once it's been positive once for H. pylori, is it always positive, or will it revert to negative again?
Good question. So serology, where you measure antibodies against HB, that stays positive several years after you've treated, because they stick around so long. So for the stool antigen test, it's a good test. So we're still a little bit early days in the Edmonton Zone. The number of equivocal results is a little bit high. It's in the range of 10%, and we're trying to address that. No, it's a good, so UBT and stool antigen is a great test to document cure, but you have to wait at least 4 weeks after the treatment is complete as one. And then for the urea breath test, you have to be at least off 3 days for the PPI, and for the stool antigen test, at least a week, because about 20%. So if you have somebody who's HP positive, but you give them a PPI, and then the stool antigen test in 20% will test negative, and then when you stop the PPI, they're positive again. So PPIs cause false negative test, urea breath test, and stool antigen test.
Mm-hmm. So if you have a patient, and I mean, you commented that if they go through the 3 iterations of antibiotics, you'll have 96% cure. But if if a person completes the first course of the 2 weeks of therapy,
yeah,
and they come back in, like how often would they be very shortly thereafter significantly symptomatic again? And
well,
then you just immediately start the second line, or?
But you see, in people with reflux disease, if they have true reflux disease, I say, you can try to come off it. My prediction is that you won't. So you take, and you remember, so they often are once a day, and during the PPI, the HP treatment, they get it twice a day. So often their symptoms are very well controlled, but I warned them and said, listen, the fact, especially if it's reflux disease, if you then stop the PPI altogether, it doesn't mean that the Helicobacter is still there. If you have reflux disease, it's the reflux that causes the symptoms, not necessarily the Helicobacter. Now, if you had an isolated, and we've done these studies, but so if you had symptoms, I scope you or you do an X-ray and see, listen, you have a duodenal ulcer, and then I treat you and then stop the treatment. So it's been shown if the person doesn't have any symptoms, that's a good test for cure. And if then a few weeks or a few months later he gets the same symptoms back, he or she, then that usually means that HP has failed. But in general terms, we say nowadays, because it's a gastric cancer, if you're going to treat, you probably should test whether it's successful. Unless the patient that's the only isolated symptom you treated them, has no symptoms whatsoever. But,
okay, good to know. So Lucas has a question, and he was wondering, how does proton pump inhibitor therapy lead to hypomagnesemia? And how common is this effect? And should we be routinely monitoring serum magnesium for people who are on long-term PPI?
No, no. The only thing is at some point that people have some weird symptoms and not doing well, you may do a magnesium, but it's so rare, it's 1 in a few thousand that this happens. And then in most people, the magnesium is just borderline low, so it's probably not clinically effective. But every 2 years, grand rounds in a hospital are given because somebody had all kinds of symptoms. And hypomagnesium, which then can cause muscle things, but this is quite profound, turns out to be the diagnosis, and PPI was the cause. So they're few and far between. So no. And remember, acid is produced in the parietal cell, which makes acid, but it also makes intrinsic factor, which we need for vitamin B12 absorption. So heaven forbid that we had to screen for, well, we do B12s often enough as it is anyway, but even vitamin B12 malabsorption due to intrinsic factor is so rare with PPIs that you don't have to screen for it. No, so you don't have to worry.
Mm-hmm. Okay, can you comment a little bit about all the brouhaha on pneumonia associated with PPIs and how worried you have to be? And
so it's not felt to be causal. There's still, the jury is out a little bit in the ICU. So where people are ventilated, and then you may have, or if they're not ventilated, they may have aspiration and so on. And whether there's a difference if you give H2 blockers versus PPIs, I'm not 100% swayed by this. So what has been shown in the ICUs is that people who have coagulopathy or evidence of bleeding benefit significantly from PPI prophylaxis as far as those complications are concerned. But to me, it's very interesting. Our cardiovascular surgeons at the University of Hospital are very concerned about the C. diff. I think there is maybe a little bit in so don't give to people that maybe don't need, but they have no hesitation after sternotomy to put people on high dose NSAIDs, even in the 70s and 80s. But don't give an NSAID, and then we get called to come in the GI bleed, and then of course hindsight is always 2020 and easy. But I'm not saying that we should completely ignore it, but to me the more important thing is, does the patient need it? Because in Quebec, when the first outbreaks of C. diff came now 10 years ago, they prohibited all PPIs in the hospital, except on special authorization, and they definitely had an increase in GI bleeds as a result of it. So, yeah, this is used.
So the Goldilocks principle.
Yes.
Okay, that sounds awesome. Well, folks, our Q&A board is open. So if anybody has any questions, we can definitely entertain a few more because we have a few more minutes. One of the things I'm practically wondering, and this is maybe a soft question, Sandra, but how do you sometimes patients are really convinced that they want to stay on the PPI. They're not keen about coming off or tapering or doing any of that. And I'm just curious about how you sort of have those conversations with people or encourage them to consider the trying of it if they're really fixed in this idea.
So what I would tell the patients is, here, listen, these drugs are tremendously safe. That's why we're so good, and they work for the right indication. So if you want to stay on it and you have been on it, it's not a hill that I want to die on. But I said most people, especially if you're older, you get more medications, would prefer not to take medications if they don't need to. So when we go from twice a day to once a day, I would be more convincing. Listen, just let's try it. You can always go back on it. To twice a day, but you just try it for 4 day weeks and see what it makes a difference. And then the same if you decide to stop for indicated or unclear, and then see what happens. But people have underlying reflux disease, or what I call the dyspepsia thermostat. So some people have had this little bit of indigestion all the time, and they go on a PPI, and there's some, they know the difference. Then you have the answer. But there's a lot of group of people saying, well, why? And reflux is a loosely defined term. And there's studies from the UK, for example, looked at what happened if you as a family doctor give an 8-week prescription for a PPI, what happens to these people? Like 70% of people in the next 12 months do not come back for a refill. So whether they went through a stressful episode in life, whether they were overdoing it on the weekends and so on. So I always say you should have no hesitation to try somebody on a PPI if you're wondering its upper GI symptoms. You're very busy. It's an easy way. It fixes a lot of it, addresses a lot of upper GI symptoms. But I always say you have to earn your long-term. You have to earn your long-term, and you earn that by proving to yourself that this is benefiting for you when you have symptoms. For NSAID prophylaxis, it's just that's a different thing. But it's amazing. People have had NSAID ulcers. They don't want to go back on NSAIDs. I tell you that. Yeah.
Well, I'm gonna remember that. You have to earn your long-term PPI. I like that. So Bale has a comment here in the Q&A. He's saying lots of his patients have dyspepsia due to eating late, due to busy schedules, and PPI works for them. Should they only take this PRN or regularly?
So very good question. So PPIs take a little bit longer, usually a few days, to get their maximum effect, as opposed to H2 blockers that work much faster. Zantac and Pepcid AC, they work very safe. If you're overdoing it a little bit on the wedding that's coming up on the weekends when you're out with your friends, the H2 blockers work faster. And if you need instant relief, antacids work even faster because they bind it. So what I say, and there are people with reflux disease and dyspepsia, always start 4 to 8 weeks once a day and prove to them, this is what I call the dyspepsia thermostat, how much you can reset, how good they're going to get, so they know how good they're going to be, hopefully improve. And then you can go to, once they've done, you can go to if they have recurrency, you say, listen, once we control, and then go to every other day, and then go to every second day. So what I'm saying is, titrate, I call that threshold therapy. To titrate yourself down to a frequency that you no longer have symptoms. But if you titrate yourself, and then after 4 days you get symptoms, and then you go for a week on it, and then after 4 days, then I'd say you should take it as a minimum every third day. In the days that H2 blockers and PPIs were a lot more expensive, it has been shown that some people have duodenal ulcer episodes 3 times a year. And if you recognize your symptoms, so you don't wait till you have ulcer, bleeds, or whatever, it was cheaper to give them 3 times 4 weeks or 8 weeks an A2 blocker in those days than treating them for 12 months. So yes, there are people that you can titrate down, and a few people. So there are some people that have just intermittent. The reflux seems to bother them, but I see, but I don't know how often it is that people say, oh, yeah, every so often I take the PPI, and then I look down, and they have actually quite a nasty esophagitis. So if I see more than grade A, so grade A is mild, but grade B esophagitis, all these people that's been shown need lifelong PPI probably once a day. And so that's what I would do.
Mm-hmm. And isn't standard practice
very important for you as family doctors to remember when we scope somebody, your patient, that we say the endoscopy was normal, 2/3 of those patients are PPI. So it doesn't mean that they didn't have an ulcer or they didn't have reflux esophagitis or whatever. So it doesn't mean that nothing serious is going on, but it doesn't give you the answer necessarily why they had the symptoms in the first place. Yeah, and you know, I don't do it as much, but there's lots of direct-to-procedure endoscopies going on. So the history is relatively quick that is being taken. They are in the PPI and they say nothing is wrong, and we took HP biopsies and nothing. But the discussion, why are you taking it? Are you really better? Usually, and this is the same thing for Helicobacter treatments. Don't give this over. I have a handout. You have to explain to people why you have to take 14 days, 4 different drugs, and what it is. And I always, for HP, I always prescribe as a blister pack, because even people like us that are well educated, you know, 4 times a day Pepto-Bismol, try 2 tablets, 4 times a day metronidazole, 1 tablet. Oh, the PPI is twice a day, not 4 times a day. It's very confusing. so just put them in a blister pack.
That's actually a great idea. So Therese has a question. She's wondering whether sulforaphate would be an option for managing GERD symptoms.
Which one?
Sulforaphate?
Sucralfate. Yeah, very, very. I mean, it used to be in vogue when I came on. I prescribe it 2 or 3 times a year when I really run sort of out of options. You think that patients may need gastroprotection. So rarely. And you know, once there's a few patients that I can sort of see, but for the most part, it is, you feel you need to do something and you don't have any good options. But if you want to gastroprotect somebody, PPI is superior. And I don't know, H2 blockers seem to, you know, I started residency, ranitidine and cimetidine just came out, revolutionized the whole thing. So sometimes you see also patients, they swear that ranitidine is better than the PPI. And what I say to them is, listen, I believe you. I'm not arguing. I don't understand it, because a PPI is major league hockey and a H2 blocker is minor league hockey, and most Canadians get it immediately. If you explain it to that. But there's a few people that say, and they say, if you're better on an H2 blocker, you know, fine with me. But usually H2 blockers generally you have to give twice a day.
Mm-hmm. And 30 minutes before people eat, correct? Well,
I don't know, 30. So the trick is just to give it before breakfast, just before 30 minutes. You know, some people, I put my cappuccino on and then I jump in the shower and then I'm done. It's ready. It's perfect timing. So I would say just when you put the cappuccino on, I would take, it's more important that they take it. So don't complicate it. And it's the same thing with the bismuth-based quadruple therapy. I used to get phone calls. You know, with the tetracycline, you have to wait 2 hours between meals. I just say, listen, the most important thing is take it 4 times a day and just take the drugs. Don't worry about whether it's with meals.
Okay, very practical tips and perfect timing. So you have some compliments in the chat box. Muriel saying, thank you so much, it was very practical. And Bao is also saying, thank you kindly, great info. So I think everyone would probably be echoing those sentiments, and they're just a great session, very practical. And we're really grateful to you for, oh, and Minnie's chiming in also saying thank you. So yeah, I think it was very, very, very helpful, very practical.
It wasn't too fast, but the slides will be available. And so my email address is there. You can always ask me for advice or give drop me a line or call me through switchboard. We definitely be help. But I want to reiterate, medicine is a team sport, and but you should feel empowered in primary care. But we are there to help you. So this will also say, as far as referrals, if you write to me and say, listen, I can't explain it, but I would feel better if you scope this patient for me, we'll do it. But if you write that on every patient, then we say, well, you know what, this Denise here is
she's a rabble rouser. Yeah, so fantastic.
So, and then I just want to acknowledge here once again, for organizing it with the PLP with these handouts. We went through several sessions with focus groups, and so tremendously helpful. So great group of people to work with.
Thank you so much, Sander, for all the support as well, and great collaboration with the SCN. And just want to thank, in the background, we have Badi and Nandini from L3PLP who've been helping out, and Melanie from the, sorry, yeah, I got it right, from the Digestive Health SCN also helping out. So thanks to all the participants for coming for the event, really appreciate it. And look forward, as always, to your feedback and comments. So if you have a moment to send a little bit of a feedback for the team, that'd be fantastic. And also here's the QR code on the screen now for the potential audit and feedback Deprescribing PPI study. For anybody who might be interested in that, please scan that QR code and share your email if you might be interested. That'd be super. Okay, so thank you all very much and have a super evening.
Thanks. Yeah, thanks for tuning in.
Great. Okay, great, guys. Bye.
So do we stay on?
Oh, we can. Yeah, we can stay on. People will just sign off. But yeah, but we can stay on. And no, super great, great session. Everybody's piling on, saying thank you. So you should.
Okay.
So
yeah.
So the tempo was not too fast?
No, it was great.
Very good.
It was great. It was very practical. And the one slide I was jotting down some notes, and because the climate was new to me, and I was trying to jot down the different regimens, and then I missed it. That's okay. I'll see it on the slide.
Well, yeah. So the reason I didn't put them in because it takes time. So I could, if you want, I can add a handout on the regimens. But if you look it up, it's in the way. So the literature calls it concomitant, but climate is clarithromycin, amoxicillin, metronidine. That's how it's much easier to remember. I think
it's good for the residents too, because that's a favorite question on the CFPC exam. So that'd be a great way for the students to remember too. That's one of the questions they always ask is what's the regimen, and then write out the doses and stuff like that.
So I forget your first name, was it Bibi?
Badi.
Yeah.
So the volume was okay?
The volume was good, was very good, yeah.
Great.
Yeah, everything was good.
Yeah, it was super.
Have a few more people.
So Melanie, so that's sort of how we do the webinar. So yeah, and I feel like we've been doing a whole bunch of GI ones this month with the cirrhosis series and the malnutrition one coming up.
Yeah.
So it's good. We really appreciate it. It's been a lot of fun.
Yeah.
The cirrhosis, I'm really excited. We're going to do a launch party, Sander, for this website. And,
I said to
so you gotta come.
I said to Pranita when she was on what's it called, was she on the other day? So we're all going to drink. And celebrate.
It's like, yeah, and she's like has her apple juice, so she doesn't take alcohol.
Yeah.
Yeah, but yeah, I know it'll be really fun. Actually, I've learned a ton with those myself. Like,
Oh yeah, they're
a lot more. You know what's interesting is with the lab requisitions, they've taken off. I think you can only order as ALT, and you can't order ALT and AST without writing it in. And then I'm watching all these things going, well, I need to do these FIB4 calculations. So then, you've got to make sure you're kind of getting it in there. And it's interesting because I've been doing it a ton more since Juan's talk. And I think that was
later in the fall. This is where I wish the FIB4 is going to be a lab test. You can just take it off.
Ah, good. Okay.
Just like a GFR.
Good. Because I think that was like there was a couple of cases in one of those cirrhosis presentations, and I was like, oh, like one of them particularly really made me take a step back, because I wouldn't necessarily have like twigged to it in when I was seeing patients. So it's really good. So we've been doing a lot more of that lately since the series. Yeah, it's very, very good.
Yeah.
I think.
Yeah, I just wanted to make sure that the slide that you provided me, Melanie, that is the slide deck that you want me to mail out, right?
Yes, Sandra, that's the one you just presented. You're good with that one, right?
Yeah.
Super. And that was very good, Sandra. Your pace was perfect, and the timing was so good too. Yeah, it was.
We should let Ashi come on. Ashi is still on in the background from Calgary. Hi, Ashi. We see you still there in the background. We should let you come and hang out with us. I don't know how to do that.
Well, I think he wants to be my, how do you call that in a play, that somebody's out, whatever, with the flu.
He says hi. Hi,
Ashi.
Oh, too funny. Sorry, I thought I signed off. He said, "Oh no, it's good. We know we can see you. We can see you lurking on us. It's awesome." Yeah, I know this whole crazy COVID. I'm just so sick of this. We can't get together. Well, this is just great, guys. So we look forward to some more activities. I think the one project we have ongoing right now with you guys is the low value endoscopy, which has been beavering along.
Caitlin has been fantastic on that project. My gosh. She's
that's
mover and a shaker. So Dan and I, usually after we have this meeting, Melanie's involved in that as well. That I said, isn't it wonderful to have a team like that? You can, it doesn't, I don't want to make it sound coming from above where, but you can just help direct, and the team is now so up to speed on it. They ask the appropriate question and say, listen, we're going to do away and we come here. Can you help us with this? And so, perfect. And I tell you, like,
a lot of fun.
And I can tell you, well, Melanie, I'm just buttering her up a little bit, but the digestive, our core team in the SCN is one of the best teams I've ever worked on. I mean, people so responsible, interested. Yeah, it's
that's awesome.
Like we are overspending in Alberta, but I think, honestly, I believe, I also look at the other digestive SCN, so if I see these pathway works, we're going to make it work. 10 years from now, we will be significantly ahead in Canada. There's no doubt. I mean, can you just imagine not having net care? I mean, I would die.
Well, I was going to say, I was, Kelly, my counterpart down in Calgary, was presenting some work that they had done down there on variceal bleeding. And
This is Kelly Brewer?
Yeah. And it was really interesting. And it was like, oh, we should do that. We should do that up here too.
Yeah.
On how do we reduce that and the different things.
Yeah.
So.
Yeah. Muriel's asking a question.
I think Calgary was just doing stool tests for HP. Is UBT better? It's not better, I don't think, right? The stool test is pretty equivalent.
Yeah. So the UBT, so the problem we still have a little bit in Edmonton is that they have set the cutoff a little bit different. So they have a higher proportion of equivocal results, which is a bit of a pain. So then they either say repeat it or then you can do a UBT. But if done, they're basically equivalent, and they're 95%. So they're really good picking out whether you have it or whether you don't, provided you.
So and you always do test a cure on people like a month after you treat them?
Well, like if I have an 82-year-old lady who had a bleeding ulcer and is on aspirin and whatever, and NOAC and so on, and there's nothing worrisome in our histology, I wouldn't always check it, and there's also, I'm not saying that you have to treat everybody, but usually so if you have a very old patient and nothing serious going on, do you really want to check biopsies in the stomach, and am I going to put her through him or her for 3 courses of Helicobacter for somebody who doesn't have ulcers at age 85? That's probably not necessary. But if you were 25, you probably would. Yeah.
But what about for us when we diagnose them just by stool test in the first place?
So what's your
Like
question?
if you have somebody if someone's symptomatic and they have pain and you test them for H. pylori and it's positive on stool and you treat them, would you, if their pain is better, would you just say, okay, good? Or would you retest them?
But if that's the only thing, so if they came in with, let's say, epigastric pain, it sounded like ulcer-like, you tested them for HP, you give them a 4-8-week course of PPI, you treat them for Helicobacter. In that case, you don't have to retest unless they get symptoms again. Yeah.
Okay. Yeah. Okay. Good. Because that's what I do, and I was like, oh, am I under testing? Good. Well, this has just been super. Well, I'm going to head off and get ready for a different talk. But so good to see you guys.
Thanks.
7 o'clock.
See you in person someday.
7 o'clock.
Yeah, 6 o'clock for me, Sander. I'm in DC.
I hope things.
Yeah. Have a good meeting tomorrow morning. It's so lovely to meet you.
Great.
Oh, actually, Muriel's asking a last question. So you don't routinely retest? And the answer to that was no, he doesn't routinely retest.
I do.
You do.
Unless it's, yes. So in most people, I would retest because they're on PPIs and all this kind of thing to document. Because remember, so 1 in 7, you fail. Most people, but if somebody is a young person comes in, there's epigastric pain, wakes him up in the middle of the night, you give him a PPI, gets better, and he's HP positive, and then you treat him, then and the symptoms disappear and don't come back, I would be okay with that. But for the rest, most people they're on other medications, they have comorbidities. No, so I prefer if you test because you think you're successful, but in 1 in 7 you won't.
Okay. Cool.
So do we
Awesome.
answer that?
Well, we did answer it. I think, Muriel, we answered your question, right? As we're just all chatting. Yes. Yes. Awesome, Muriel. Okay. Have a great night, everybody.
Yes.
Okay. Good night.
Bye.
Bye.